Good afternoon and welcome to the State of Patient Matching, today's best practices and tomorrow's possibilities, a health system CIO Media Inc. production produced in collaboration with CHIME and sponsored by QuadraMed. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO and I will be your moderator today. We've got some interactive features that we're looking forward to doing during the event. One is our fun agree or over-the-top poll, which we hope you'll participate in. Also encourage your questions and comments. You could submit them at any time. In the right-hand side of your screen, look for the Q&A panel. Leave the default set for all panelists, and we'll take those later in the program. And you could download the deck by using the URL on your screen, and it's been sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to go about 35 to 40 minutes with our main panel discussion, and we've got today Mike Martz, SVP and CIO at Mount Nittany Health, Albert Oriol, VP of IS and CIO at Rady Children's Hospital and Health Center, and Letha Stewart, Director of Customer Relations with QuadraMed. So, without any further delay, we are going to jump right in with our good time conversation. So, overview and roll. Mike, you want to start us off?
Sure. Good morning, or I guess afternoon for everybody. So I am Senior Vice President and CIO for Mount Nittany Health, which is a independent community hospital and health system. Just in scale, we're 260 licensed beds, 350 medical staff, 180 of our medical staff are employed by the providers. We have about 20 clinic locations over 3 counties. We're a CMS 5-star quality rating for those who care about that. And we've done that twice now. We also operate a regional health information exchange that is connected to the Pennsylvania State HIE. There are 5, I think, regional HIEs in the state of Pennsylvania that are officially supporting the state, and they're all interconnected through the state HIE. We have about 15 other hospitals on our network along with us.
All right. Very good. Thank you, Mike. Albert?
Yes. So I'm Alberto Oriol. I'm the CIO at Rady Children's Hospital and Health Center in San Diego. I've been here for 12 years, in this role, 13 years, I guess. Rady Children's is the region's pediatric provider of choice and also the tenet provider for pediatric care in the region. We manage 524 licensed beds across a main campus and also 7 different hospital within hospital facilities in adult hospitals, whether it be NICUs or pediatric units. We are responsible for over 250,000 capitated lives. We have over 5,000 employees, 1,200 or so physicians, 1,500 nurses. Last year, we did over 20,000 admissions, over 20,000 surgeries, looking at ED and urgent care visits. Annually, we're at over 150,000 visits as well, 250,000 specialty visits, close to 500,000 on primary care visits. So we're the largest pediatric provider in California.
Very good. Thank you, Albert. Letha?
Good morning, everyone. My name is Letha Stewart, and I'm the Director of Customer Relations, as Anthony pointed out. I've been with QuadraMed for over 20 years, and in all that time, we've been offering MPI cleanup services and eMPI software. Our goal is really to help customers solve the problem of patient matching and linking records across domains in order to facilitate health information exchange and new to all of us, accountable care organizations. Our goal is really to provide the best possible software and services to help you maintain your patient information in the best possible form.
Excellent. Thank you, Letha. All right, let's get to the meat of it. So, how are you handling patient matching? So give us a little bit of information about sort of how you go about it, and how has your journey changed over the past few years to try and improve things, and have you improved things? So, Albert, you want to start us off?
Sure thing. So we are an Epic shop. We use the Epic MPI to help us with that. Up until about 18 months ago or so, we used our own proprietary algorithm that we put into the Epic system to help us with matching. About 18 months ago or so, we adopted the Epic updated foundation algorithm that seems to be working better for us. And basically what we do is we use a set of criteria to help us match the patients using weights for names and date of birth and the gender of the patient. With these typically have higher weights, and then we use other pieces of information that maybe are not weighted as heavily, including the patient's address and phone number, etc.
Okay, go ahead.
Yeah, and so we do that querying up front when a patient initiates a contact with the organization to see if that patient already exists, or if we need to create a new patient record, and then if something is indeed already in existence, the person with that interaction will get an alert to say, hey, there's a potential duplicate. Does any of these other patients match the person that you have in front of you, or on the phone, or however that interaction happens to happen. We also run a continuous query behind the scenes to look for the potential creation of duplicates. Have we created a duplicate patient? And then we have about 3 FTEs behind the scenes that work that process for us.
Yeah, it's interesting, Albert, right? Sometimes I think we don't remember that not finding an existing record is, I don't know if it's as big a problem as matching someone with the wrong record, but it's still a significant problem, because then you've got multiple records and you may not be, have all the information in one place, and you don't realize it. We have other information that's in another record that could be very pertinent, but you don't even know it. So it's as big a problem. How would you describe it? Just different degrees?
Well, yes, they're I think 2 sides of the same coin. One is problematic because you are likely operating with wrong information when you match a patient to the wrong record. Obviously, you're bringing into play erroneous information. On the other one, the other case, what's going on is you are dealing with incomplete information, which can be equally dangerous. For instance, if you're missing allergies or things of that nature that could eventually result in the wrong decision for a patient and patient harm.
Very good, Mike. Your thoughts around what you've been up to and all that?
Sure. First of all, our situation is kind of similar to Albert's in terms of our structure. We use the Meditech EMR and its EMPI, but because we operate an HIE, Health Information Exchange, we also have an HIE platform with its own EMPI, and we rely on it for the main matching algorithms. we have all the same problems and the same processes. We have a team in our medical records department, our HIM department that I also oversee, who is constantly dealing with the mismatches or the no matches or the unsure matches, and also dealing with where we have created duplicate records going through the patient merge process, both in the health information exchange but also in our Meditech EMR to clean up those issues.
Very good. Letha, what are you seeing out there in terms of how people are, in general, your thoughts on how they're tackling this today, and have you seen an evolution over the past few years where sort of the thought process of how to go about this is different than it was 2 years ago, 3 years ago?
Well, I'd like to say that duplicates in the last 20 years and overlays, which is what we call those situations where the wrong person is overwritten with someone else's demographic information that causes their clinical information to be incorrectly joined. I'd like to say that those have reduced in the last 20 years, but they haven't really. They've continued to grow. I think what we've seen in the last few years is that some of the more current situations in healthcare, some of the more current requirements in healthcare have made patient matching, duplicates, and overlays more noticeable and more concerning to organizations. 20 years ago, I used to be told fairly frequently by the CIO or CFO, oh, that's a medical records problem. I'm not too worried about it. But nowadays, I think everybody understands that it doesn't just impact medical records or health information management. It impacts the entire organization. So I think the perspective has changed in the last few years.
Excellent. All right. Next question. Why is patient matching such a thorny problem? Mike, why is this so difficult?
Matching algorithms are just an estimator. That's all they can do. And there are so many instances that all of us face where the patient information is just too close for the algorithm to get it right. So we do wind up with mismatches, and they can create actual patient harm if we don't catch them up right. So the way that we adapt to that is on top of the automated systems, the EMPIs, we're having to back them up with manual effort to clean up the messes that the EMPI can't. Albert talked about 3 FTEs that he has full-time doing that. I've probably got about 1.5 to 2 FTEs doing the same thing. That is a cost that we have to incur until we get to something more accurate than where we currently are. I think that most of the systems that have very finely tuned matching algorithms these days, what I hear is they have roughly a 90 to 95% accuracy rate. Well, if you take, let's take it at a state level. If you take a state like Pennsylvania that has 12 million citizens, and you've got a 95% accuracy rate, which is probably about as good as any of the state level HIEs get, that means that you are misidentifying 600,000 patients a year. That is a level of quality that no other industry would accept. Can you imagine if the airlines thought that they were doing good if 1 out of every 20 flights crashed? We have to do better. It is unacceptable for us as an industry to be doing things at that level. And unfortunately, the only way that we can deal with it now is through expensive manual labor.
Very good. Letha, your thoughts on why this is such a difficult problem?
I think it's a difficult problem for several reasons. The first one is that, in general, data quality is often poor within the databases at a hospital within the NPI. That's partly because patients don't always give the best data, and partly because the patient access staff is in a hurry and often is collecting it as quickly as possible and maybe takes some shortcuts. I think the second reason is that the data ages quickly. people come to the emergency department, come to the hospital, they give you their patient data, but then 2 weeks later they move. Well, when they move, they don't call up the hospital and say, oh, I just moved, here's my new address. You don't get that updated information until the patient comes back. And so that can be a problem. We also run into a lot of times difference in data collection policy. So we have customers where the hospital uses the driver's license as the source of truth, but the physician practices use the insurance card. And if the name on those don't match, then you may have an issue. And then, you know, poor system functionality to a certain extent. Not every system on the market does a very good job of matching patients when you're searching at registration or when you're trying to identify duplicates or overlays on the back end. So there's a number of reasons for it. And it does, you know, it does mean that we do have to do some manual work, as Mike pointed out.
Very good. Albert, you mentioned, you know, you can tackle the question at that high level, and you had mentioned this issue of weights and using different weighting for different fields or different factors, pieces of data. That's kind of interesting. So if you want to answer the question at large, but also more about the weights, I'm wondering how you decide what data point gets what weight. Is that some sort of, does anyone establish the standard for that, or you guys come up with your own?
Thank you. So we used to come up with our own, but I think through partnership with others, now we use Epic's standard. We do make some selections. For instance, in the pediatric world, particularly when it comes down to the neonatal world, kids don't have social security numbers, right? So that might be a piece of information that other institutions weigh more heavily than pediatric institutions will typically will weigh because for a portion of their population, it's a data point that's not available. I was going to just give you a couple of examples, and I'm thinking if I were to ask you, how many Maria Garcias do you think we have in our MPI? What would be your guess? Right?
I don't know, Letha, you want to guess?
Well, I used to work at a big teaching hospital, and we had 4,500 patients named Juan Gonzalez, so I'd say pretty high, probably a couple of thousand at least.
Yeah. So you guys get the drift, right? There are a number of patients with the same name, and in many cases, same name and same date of birth, and so that alone presents an issue, right? When it comes down to pediatrics specifically, we run the issue of transfers from labor and delivery hospitals in the community to our NICU, our neonatal intensive care unit. In many cases, these babies still don't have names, right, when they're transferred to us. So challenges of matching the information that comes from the birthing hospital to back to us is problematic, and we've done a lot of work in the community to develop standards and naming conventions so that when it comes down to exchanging information, we have a chance of actually finding the right patient and getting that information to flow over. But it's as I said, challenging and problematic on multiple levels, not just because of the reasons that Mike and Letha have discussed earlier, but it gets further complicated in our case in pediatrics with some unique situations.
I think one
very
of the
good. Go ahead, Letha.
Sorry, I was just gonna follow on to that. Because we do so many MPI cleanup projects where we look at really large volumes of duplicates, one of the things that we see a lot is Anytime there's a multiple birth, twins, triplets, things like that, you have to be very careful because it seems to be the trend to give them some sort of name that's very similar. We've seen male and female twins named Eric and Erica. We've seen twins named Maria B. Gonzalez and Maria B. Gonzalez, only to find out they were Benita and Bernice. So not only is the pediatric population kind of unique in its challenges, but when you build in the multiple births and things like that, it's even worse, and it makes it much harder for an algorithm or even a human sometimes to confirm that those really are the same person.
And yet, even outside of pediatrics, I remember 30 years ago when I was taking our firstborn to see the pediatrician, her name is Amanda Martz, or was then, and they had another Amanda Martz patient that was the same 3-year-old age, and both dads were named Michael Martz. The mom for the other girl was named Linda Martz, and my wife is Lindy, one letter different. So the opportunities to blow the algorithm out of the water are very common.
All right, excellent. I want to focus here on common errors because we touched on some things on this slide already. Letha, do you see when you go in and talk to clients, potential clients, are there a few things that you've identified as common errors or common mistakes people make when trying to tackle this problem that's really not going to get them where they need to go?
Well, I think the first thing that people tend to do is maybe keep their head in the sand and ignore it until some event comes along, like a conversion or a patient incident where a patient is harmed that makes them, forces them to actually pay attention to it. This is really an ongoing commitment to patient quality and, data integrity. I think the other thing that we see is that sometimes people think, well, if we do a cleanup project and get the data all squared away once, we're good and we can sort of stop thinking about it. Or maybe we'll install an EMPI and that'll take care of it all. And it really takes a combination of the two. You've got to have some method of identifying duplicates consistently and overlays consistently. And you've got to have at least some human component to review the things that can't be done by the system. And when you try to do just one or the other, you tend to fall short. The other thing, and I kind of alluded to this earlier, is even today sometimes we'll go in and talk to an IT department who's interested in software, and they've not really even talked to the HIM department, so they don't even really know what's happening in the organization. So just generally, knowledge, I think is one of the most important things, and people often just don't pay attention to it until something happens. There was actually an incident, I think last week, that was all over the internet, a hospital in New Jersey, kind of back to your comment, Mike. There was a hospital in New Jersey that had 2 patients with the same name on the organ transplant list. I assume they were also on the list for the same organ because they actually got an organ for patient A, but they transplanted it into patient B. Luckily, another organ became available, and they were also able to do the transplant for patient A, but something as simple as 2 patients with the same name on the organ transplant list for the same organ can cause, potentially significant harm. In this case, luckily, the patients were okay, but think about the consequences if they had not been.
Albert, any thoughts here on either on mistakes that you've made or things that you think people might be tempted to do that you don't think would work out?
Yeah, I don't know if it's so much things that don't work out, but it's definitely things that are not the most efficient, and that is throwing people at it, right? But it's what we're all kind of faced with because the algorithms only take you so far, right? And then, of course, the other mistakes have to do with human error and and attention to detail and trying to get through seeing the one patient so you can move on to the next, et cetera, et cetera. And that's something that is just the reality of the world we live in, and trying to ensure that this is something that is front and center on every person that touches the patient. That patient ID is a critical component of our patient safety efforts, that our patient access reps, our registrars, et cetera, our schedulers know that, realize that, are reminded constantly that there's constant awareness that this is kind of a fundamental piece on our institution's ability to provide safe and proper care is key. And so I think errors having to do with taking our focus of that fundamental need for awareness and ongoing training is something that is not unusual, particularly when organizations go through tough financial times and they have to tighten belts, etc. It's not unusual for education to be one of the first things that kind of gets laxer, and that's something that in this particular case it can have big impacts. So in general, to me, those are the two big things. And then I would say the third one, and this is more at a time when we're really, as a nation, trying to improve our efforts around health information exchange, is still a tendency for organizations to look inward and to, I don't want to say take a parochial approach, but to some degree is to kind of prioritize other, internal institutional issues above kind of a more holistic view across the community. And so I think those communities that have managed to come together, to bring their HIM professionals together, to figure out ways to collaborate, to find common solutions, are going to have a leg up on others where people are kind of more inward looking into their own organizations and their own organizations only. So if
excellent. Oh, go ahead, Albert.
So I'm going to throw a shout out to Dorothy O'Hagan, who's our Director of Health Information.
Nice.
And also she's responsible for our clinical information systems because she led this coalition in San Diego to have all the entities agree to this naming convention for babies in the NICUs that has been tremendous in terms of helping our clinicians truly identify those patients and bring information over from those patients birthed in other hospitals. And this has been really life-changing for the clinicians in our NICUs, and it's taken a tremendous amount of work, many months, for people to agree to changes that involve changing their own institutional policies and procedures, et cetera, but to come up with a community standard that now is resulted in much faster care and better care for those very fragile patients. So I think that ability to collaborate is key.
Excellent. Thank you, Albert. Mike, your thoughts on common errors, and also if you want to touch on, just expand a little bit more about this, the concept of having to go manual in this and have FTEs focused on this. I don't know if you've got any thoughts around how many FT or how much. So you have a volume that you need to handle. How do you know how many FTEs you need to handle that volume? Is there any standard out there that people can use? And how do we get away from it? Obviously, manual, I guess it's necessary, right, for now, but it doesn't scale. It doesn't scale very well. But go ahead, your thoughts.
No, well, as a career-long technologist, it hurts me to say the biggest error I think organizations make is trusting the technology. Unfortunately, with matching algorithms, they're just not good enough that we can trust them yet. And I think a lot of organizations are tempted to kind of set the threshold lower in the matching technology so that more things are matched automatically rather than thrown out for human intervention. Normally, in these matching algorithms, you can set rules that say, for example, if 4 fields match, then consider it a good match and make it automatically. But if only 3 match, then or less, then kick it out to a human to review. And as Albert mentioned about all of us facing cost pressures, it may be tempting for some folks to lower that threshold to say three fields matching is good enough to reduce the human effort. But it's a risk that you take in that the automated algorithms are going to start to make more wrong matches automatically that humans will never see. I think we have to be very careful as organizations and as technologists not to trust the technology too much. Let more things fall out and be reviewed by human people. But obviously, you've got an effort and a cost to do it. If you're not cautious, you're going to have patient errors that could wind up harming or even killing somebody.
I'd like to
Letha,
add on to that a little bit.
Yeah, can I frame something for you? Yeah, I just want to let me frame it for you, and then you can jump in. So, what are your thoughts around manual? How far can the technologies take us? And what Mike had said about having people absorb some or review some of those. Is that necessary in your mind, or just what are your thoughts on what the technologies or what technologies like QuadraMed can do and the level of accuracy it can take people to?
I think that's a really good question, and it's kind of along the lines of what I was going to add on. When we first started, because there's a couple of different levels of matching. So there's the initial level that says there's a potential that these 2 records represent the same person. And that's what most algorithms do. They start off with, these are possibly a match, and we believe the weight of that possible match is X. And then there are usually business rules that say, given enough factors, such as Mike's example of, 3 things match, 4 things match, we're going to automatically or programmatically link it together with no human review. So there's 2 kind of levels there. Mm-hmm. When we first got involved in that second level of saying, okay, what has to match? What has to constitute? What has to be the same to constitute a match? Many other vendors were saying, if the weight is above X, you're good to go. And again, with our experience in doing cleanup projects, we know that just because 2 records have the same weight doesn't necessarily mean, or 2 duplicates have the same weight, it doesn't necessarily mean that both of them are going to turn out to be the same person. And so we actually built in specific, not just 3 elements or 4 elements have to match, but specific elements, last name, first name, gender, date of birth, whatever. We would accept a variation in the last name on a woman, but we wouldn't accept that on a man. So if we had Letha Stewart and Letha Jones and enough information, that would pass. But if we had Mike Martz and Mike Mertz, someone would have to look at that because men don't change their names. So it's definitely important that those rules that you use for matching are specific and that you have what we call failure points. You have specific things that get kicked out, like one of ours is if the gender is different, it falls out into the review queue for someone to look at because it could be an overlay where 2 different people have been linked together incorrectly. So we want someone to look at that. So you really have to focus on what is that matching? And then in terms of the human component, yes, I think there's always going to be some human component because there are always those ones that either have very sparse information, just a name, a date of birth, and nothing else, or are very, very similar, like Mike's example of his daughters at the pediatrician. In those cases, someone has to look at it and do further research to confirm that it's the same person. Or you do run a significant risk of matching people who aren't the same.
Very good. All right. Obviously, there's a lot of policy implications for for something like this. So, Mike, you want to start us off? I know you're very involved with CHIME and Albert too, but Mike, you want to just get us started and tell me what you know about what's going on the policy front. I know CHIME's big advocate of an NPI, done a number of things to try and move that along. I don't know the degree to which there's been success. But if you want to just tell us about what you know about what's going on the policy front.
Sure. So I hope a lot of people know that there's been a lot of debate over whether we need a national patient ID for, what is it, Albert, 20 years or so since the government was first charged with creating something like that, but then immediately banned from doing it by Senator Ron Paul. CHIME has, and the Policy Steering Committee has been lobbying, and successfully lately, to try and get the federal government to be allowed to work on this problem. And we've had great success this year thanks to our crack policy team in Washington, where the House now has passed legislation that will let the government get engaged in this. It's through the budget reconciliation process. And now it is to the Senate and the budget reconciliation between the House and the Senate to see whether that permission can be preserved. We hope that it can, but if not this year, we'll keep trying until we get it, because it is, in my view, it's critical for us to be able to get beyond the levels of accuracy that we are now. I think, frankly, we as an industry need to be looking for 99.999, possibly another 9% accuracy in our patient matching, and we just can't do it with algorithms. We have to have a national patient ID. The big pushbacks on the patient ID are frankly around security and privacy, especially privacy. Mm-hmm. And the privacy advocates, I think, have a very good point about being worried about it. I think, frankly, all of us hospitals do as well. Just briefly, we had an example at a past hospital of mine where we had a patient come in for a routine gallbladder surgery. He had the surgery, and then he found his insurance company wouldn't pay for it because by their records he had already had it. And what he found is that his brother had used, possibly with his permission, his insurance card to get the same surgery 5 years earlier. And so he was stuck with the bill, which in rural Pennsylvania, where I was at that time, that means that we were stuck with the bill because it was hard to collect on this patient. That happens with hospitals all the time. So we have as much concern about patients' ID being protected and not being misused, frankly, as the patients do. We need the government to work with the industry to come up with a solution that both gives us the accuracy we need, but also the level of privacy and security that we need so that our IDs don't get misused. We all need that to happen.
Letha?
I would agree with Mike. I think that the National Patient ID is really the biggest thing at the moment as far as policies go. As I said before, meaningful use and accountable care organizations and health information exchange have all increased the awareness of the duplicate and patient matching problem, but the National Patient ID is definitely at the forefront of everybody's mind right now.
Mm-hmm. Right. Albert?
So I echo what has been said. I will offer this thing, right? As I'm an immigrant to this country, and I applaud the ingenuity and the pioneering spirit that we have in this nation. I think this is one area where we don't have it right. The rest of the world has figured it out, and they do a much better job than we do, and that's because they subscribe to a national patient ID. We don't. It's time for us to own it, realize that maybe this is one area where we should emulate the way it's done elsewhere, and get there faster and better than we are currently doing today.
And if I could add just a little bit, this is kind of broadening the discussion just slightly, but the reason we're so focused on this is because we're trying to share information electronically. And that has been the major focus of the government for the last 10 years with us, is getting interoperability to move better. There are, at the policy level nationally, that there are a couple of other things that are also active, just for people to know. One is a push for better data standards, so that we can exchange information without the coding and testing and configuring that we all go through right now. Our standards are way too loose, and as a result, much of the data that we receive from other organizations is often not usable because the standards are too loose. I think we all see that in the CCDs that we exchange back and forth. And unfortunately, as much as FHIR is held up as a kind of savior of the industry on interoperability, it suffers from the same problem. We currently, with FHIR, I've seen people who are on the committee building the FHIR standards complain that the standards, for example, will let FHIR transmit a problem list, which is great, but it's optional whether you transmit the status of the problem. So you may get a list of 50 problems that associated with the patient, but only 5 of them may be active problems, and the other 45 are old problems that are no longer relevant. But if you don't send the status, the receiving doc may not know that and try and treat the patient for something they don't have anymore. The other thing, and I think this is equally important to all of us, CCDs have been put forward as kind of the standard way for information to move back and forth between organizations. And unfortunately, the receiving organizations generally don't use them. We're pushing a lot of data around, but it's not being used at the receiving end, partly because the standards are so poor that we can't ingest it. So another policy thing that I hope gets more traction in Washington is pushing our EMR vendors to be able to extract more information, more discrete data, but also just reports out of these CCDs and ingest them and use them within our own native EMRs, just as our own data is.
All right, very good. We're going to go with our little fun agree or over the top poll. So I'm going to open that poll right now. And if the audience would basically select for these statements whether you agree with them or you think they're over the top. And then we're going to ask each one of our panelists one of these questions. So point number 1, statement number 1 is an NPI is essential to solve the patient matching challenge. And I'm going to give that one to Letha.
I think it's essential, but I don't think that's the sum total of the solution. Because even if we are successful in adopting an NPI, we have a significant amount of historical data that we still need to link up to that new number. We have newborns, how do they get an NPI? We have immigrants and visitors. So I think it's a great beginning, but I don't think it's the sum total of the solution.
All right, very good. Next statement, and I'm going to give this one to Albert. Privacy concerns voiced in opposition to an NPI are extremely exaggerated. Do you agree with that statement, or is it over the top?
I think this statement is over the top.
Okay.
I will qualify what I think they are exaggerated. I don't think they are extremely exaggerated. And Mike, I think, pointed it out earlier. There are valid concerns. Having said that, I don't think that the alternative solutions that we are dealing with today do any better a job at protecting patient privacy, and instead they increase the risk from a patient safety standpoint. And so in that regard, I will tell you, my own opinion is I value my safety and personal integrity above all else. Or if I were to ask to put this in, say, the case of my son, I'm willing to establish a priority that has safety as number one and privacy as slightly lower priority. And when those two come in conflicts, safety comes first.
Very good. All right, Mike, you're going to get the last one. Patients are routinely, and again, that can be defined any number of ways, but let's just go with it. Patients are routinely harmed as a result of patient matching errors. Do you agree with that statement, or is it over the top?
Well, if you consider routinely that more than one patient is harmed daily somewhere in the country, absolutely, I agree with it. We heard from Letha the example of transplant. We've heard of examples of DNR orders getting mixed up with the wrong patients, and someone who should have been resuscitated was not, or someone who should not have been was. And certainly wrong medications being applied. That happens constantly.
All right. Let's look at our results, and I'm going to share those right now. So you should be able to see those. And here are the results. So for an NPI is essential to solve the patient matching challenge, 58% agree. 34% say it's over the top. For privacy concerns voiced in opposition to an NPI are extremely exaggerated. 63% say it's over the top. Only 26% agree with that statement. And patients are routinely harmed as a result of patient matching errors. 53% agree that patients are routinely harmed. That's a scary statement, right? So we want to get better. All right, let's get in. Actually, I want to take care of our audience here. So let me get to an audience question. I have one for Albert. When you mentioned, quote unquote, work in the community in regard to children's matching information, what type of work in the community did you mean?
So in this particular case, the effort is an effort that took months and months, led by, as I mentioned, one of our leaders who's very active in the community HIE, and working with her counterparts in local institutions, working with the legal counsels in many cases and privacy officers in these various institutions to design, identify problems, prioritize them, try to find common solutions. In this particular case, I was talking about a naming convention for babies, which required then each of these people to go back to their own organizations and potentially drive changes in their policies and procedures on how they handle those types of things, kind of make those agreements, put them, then run through the implementation, continue to tweak, because seldom these things are gotten right on the first go. They tend to require some adjustment as they go along. And again, this is gruesome work, right? It's not you flip a switch and it's not a toaster. You plug it in, insert the toast, and wait a minute and a half, and it's done, right? This just requires rolling up one's sleeves and working with others to find common ground and agreeing to solutions that work.
Makes me think of data governance. Go ahead, Letha.
Sorry, I was just going to add to that. I started to say this earlier. That's a massive achievement. We have worked with many, many hospitals that can't get their own internal teams to agree on patient naming conventions, much less to get a group of organizations within the same community to all agree to use the same one. That's a huge achievement. Believe me, we understand what that takes because, like I said, most facilities can't do it internally, much less get agreement from others.
Thank you. Yes.
All right, very good. One more. I want to get in one more audience question, then I'm going to let everybody get going. So the question is, and I'm going to go first to Mike on this. Do you agree that biometrics should be a part of any positive person identification in the future, that it should be an element of a national health safety identifier? Mike?
I think that it is a viable option. It's not one that I see a reason to dismiss. I'm not set on it. If someone comes up with a better option, by all means, we should consider it.
All right, very good. Albert?
So I think it's a potential part of a solution, but I will qualify it by saying this. Do you need a Maserati to go across the street? Probably not. Right? It's you can walk across the street. You don't need necessarily to ride a car in a high-tech car. So there are instances when you're going to get in a racing track where you do need a Maserati or equivalent so that you can perform at the expected level. And there are instances where biometrics are going to be key. But I think there is a much simpler starting point if we could all agree. And when I say all, I mean the folks in DC mostly agree that this is the way to go, and that's the start with an MPI, and then all the other technological advances that help us ascertain that will be welcome. But I think, as I said, it's part of a solution, but it's not necessarily where I would start myself.
Letha, I'm going to give you the last word. Give me your thoughts on biometrics as a component of a solution, and then if you want to give me your overall thoughts that we can send people on our way with about maybe how they can frame their attempt to solve this problem in their own shops.
Certainly. From the biometrics perspective, I would agree that I think it's a component of the solution, but it's not the entire solution. Biometrics are not foolproof. We've had, situations with customers that use biometrics at patient registration who still have created overlays or still created duplicates, even though the patient has scanned their palm or, done their fingerprints. So it's not a fail-safe solution. I wish it was. As far as leaving you with some thoughts, I think the number one thought I would say is that accurate patient identification or poor patient matching, however you want to think about it, is not an HIM issue. It's not an IT issue. Really, it's a patient safety and risk management issue. Because if you get it wrong, the person that stands to have the most harm is really the patient. And then the organization is on the receiving end of whatever lawsuit that might result in. I do think that we've talked a lot about policies and standards and naming conventions, and those are key. That's one of the reasons that we struggle so much today and have so many problems, is that there are no consistent standards. You asked earlier if there were consistent standards for data collection. No, there are no standard requirements for algorithms. There are no standard requirements for a lot of things that we do in healthcare. And then back to one of Mike's comments, as much as we hate to use the money that way, we do have to assign human resources to help resolve this problem, at least today. And it's too easy to cut that or cut the technology when you're looking for a way to save money.
Excellent. All right. That's about all we had time for today. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our event. So let CHIME know you were here. And if you've asked us to do so, we certainly will. You'll receive an email when the on-demand recording of this event is ready for viewing. If you'd like to sponsor an upcoming event with us or book a custom event, you can visit our website or reach out to Nancy Wilcox from our team. And you can go to our website to register for an upcoming event. With that, I want to thank our panel. What a great conversation and lots of good information today. Mike Martz, Albert Oriol, and Letha Stewart. And I want to thank QuadraMed for sponsoring this discussion and making it possible. I think a lot of people have been helped today. And I want to thank you, our attendees, for coming to our events. So with that, everybody have a wonderful day. Thank you.
Thank you.
Thank you.